Good morning, everybody, and welcome to American Safety Programs and Training. Review of Chapter 15, Respiratory Emergencies. This is my first time recording myself, discussing a chapter or teaching a class, so if it seems like sometimes I step over my tongue or seem a little confused, please bear with me. So, Chapter 15, Respiratory Emergencies. Respiratory. What does respiratory mean? Respiratory refers to our act of breathing. So we're going to discuss the act of breathing, what happens, how do we breathe, what parts of the body are involved, how do they work, and we're going to discuss the different types of respiratory emergencies and what we can do for them, and also what causes them. One thing that you'll find is that when it comes to respiratory emergencies, or when it comes to the respiratory system, just as in the with the heart, a lot of things, when one thing happens, a lot of other things happen. It's a domino effect. And it's up to us as EMTs to try to figure out, number one, what's going on. Number two, we need to understand a lot of different things that could cause that to occur with whatever's happening with the patient. And then what can we do as EMTs at our level of training to either stop what's occurring or to slow it down in order to give us time to get to the patient, stabilize them, get them to the hospital where they can have more definitive care with nurses and doctors who have a higher degree and who can deliver a higher degree of care than what we can. But anyways, okay, so let's talk about respiratory emergencies. First of all, when a person has difficulty breathing, that is called dyspnea. I might be mispronouncing it. A lot of different words I mispronounce sometimes. But dyspnea, dyspnea is the difficulty breathing. A lot of times patients chief complaint is that, and a lot of different things can cause that. One of the most common things, if you're having difficulty breathing, you could be an athlete or you're doing something physically strenuous on the body, and that's causing you to breathe more. It's causing your respirations to increase. If you have some type of disease or injury or previous damage to your lungs, that could be giving you difficulty breathing. Or it could be exercising. Or it could be you have a panic attack. So it's up to us to try to figure out what's going on. So let's look at the anatomy of respirations. First of all, what is a respiration? Respiration, the principal functions of the lungs is respiration, which is the exchange of oxygen and carbon dioxide. Okay? When we breathe, that's called a respirate. When we breathe in, we breathe out. When we bring air in, we breathe out. We're ventilating our bodies. One breath in, one breath out. That's called ventilation. Respiratory therapists who specialize in breathing use certain tools and techniques to measure how effective our breathing is. One thing that they do is that they measure our tidal volume. Tidal volume is the amount of air we move in and out of our lungs within one breath. Then they measure that by the number of breaths that we do within a 1 minute period. And that's called minute volume. How much air do we move in and out of our lungs within 1 minute? Based on that information, can help them determine whether that person is obtaining enough oxygen and whether they're breathing normally or not. And if they're not, they have certain procedures and medicines that they can prescribe to assist us to improve our ventilations. When you actually have the exchange of oxygen and carbon in your lungs, that process is called respiration. But there's another process I'm going to teach you guys today about. It's called diffusion. So the anatomy of the respiratory system. It consists of the diaphragm, the chest wall muscles, accessory muscles of breathing, and the nerves to the muscles. You have the upper airway, which consists of structures above the vocal cords. That's the nose and your mouth, otherwise known as your nasal pharynx and your oral pharynx, your jaw, your oral cavity, your pharynx, and your larynx. The functions of the lungs is respiration. Its process is to exchange oxygen and carbon dioxide. Air travels through the trachea and into the lungs, then it goes into the bronchi and bronchioles, and then the alveoli, or otherwise known as the alveoli. Basically what happens is when we breathe, we take a breath in and then we take a breath out. There's a lot of things that make that happen. If anybody's ever seen somebody play an accordion, squeeze in and out, in and out, by doing that, sucks air in, sucks air out of the accordion. That allows the mechanics of the accordion to work and you can hear the music. We have something like that in our bodies. It's called the diaphragm. The diaphragm is an organ that divides the chest cavity from the abdominal cavity. It's the diaphragm. And the diaphragm goes up and down. When the diaphragm goes down, it creates a sucking pressure, or it creates a sucking motion in our chest cavity by creating negative pressure. When it creates negative pressure, that causes our chest muscles and our chest and our rib cage to go up and expand. When we breathe, we go, we breathe in, we breathe out. Okay. You also have muscles that are between your rib cage that help you breathe as well. That helps your rib cage expand to bring in as much air as possible, and then they relax and the rib cage goes back down. That's normal. It's normal size. Individuals who are having difficulty breathing, you might see what they call accessory muscle use, and it's usually the muscles in the clavicles and the muscles in between the ribs. Now, the muscle in between the ribs they're called your intercostal muscles. Okay, it's part of your skeletal muscle, but those muscles are designed to help you breathe. As I said earlier, they help your lungs get bigger and then go back to normal size when you breathe in, breathe out. When you breathe in, that's called the active phase of breathing. When you exhale, that's called the passive phase of breathing. So active, passive. Okay. What happens is that somebody who's having difficulty breathing, their chest muscles are having difficulty working. So you're going to have your accessory muscles, and the muscle up here between your clavicles, you're going to actually see them suck in when they attempt to take a breath in. Those muscles are sort of like the backup muscles for the respiratory system. Those muscles are going to work, and they're going to tighten, get really, really tight in order to help allowing the chest to expand. And you're going to see the muscles in your clavicles and in between your ribs, and they're just going to suck right in between the ribs. So you got a rib here and a rib here, and the muscle normally goes like this, and this is the inside of your chest. The muscle is going to get sucked in, and by doing that, it's going to help you breathe. And that's what we refer to as accessory muscle usage. So when the air goes into our body, the air goes in through our nose, it goes in through our mouth, it goes down through our upper airway. It goes into the trachea, it comes into the bronchioles, and then, it goes into the bronchioles, and it goes down, comes into the main bronchi, then it splits into the bronchioles, which are smaller branches inside the lungs. And it delivers that to the individual groups of grapes. They're air sacs in your lungs. They're called the alveoli or alveoli. Most people call them alveoli. There's thousands and millions of bunches of grapes within your lungs. And if you look at page 587 or page 586, you're going to see what they look like. And the walls of those grape bundles, or the alveoli, is so very, very thin. And wrapped around those is a fish netting called your capillaries. The capillaries come from your arteries and your veins, and that's where the blood flows. So there's a process at the walls of the capillaries, or the walls of the bunches of grapes, that as blood is circulating through that netting, or through your capillaries, because the membrane is so thin, the higher concentrations of oxygen that's in your lung, of oxygen molecules, and the higher concentration of CO molecules that are in your blood, they actually pass each other, and the oxygen actually goes from your alveoli through the capillaries, through the membrane, into your blood, and latches on to the hemoglobin on the red blood cells. And at the same time while that's taking place, the high concentrations of carbon, or CO, leaves your bloodstream, goes through the membranes, and goes into your alveoli. And then when you exhale, you breathe that CO out. That process where higher concentrations of molecules in one area move to an area of lesser concentration of molecules, that process is called diffusion. So in the lungs, you have a higher concentration of oxygen molecules, but in the blood, you have a lower concentration of oxygen molecules. So what they do is the oxygen molecules of higher concentration moves through the membrane, through the capillaries, into the blood, because there's a lower concentration of oxygen molecules. At the same time, you've got a higher concentration of CO molecules in your blood, but a lower concentration of CO molecules in your lungs, and they go from the blood into the lungs, and then we exhale it out. And they're like two ships passing in the night, oxygen carbon or oxygen CO, and they just pass. And that process is called diffusion. Okay? Once the oxygen is latched onto the hemoglobin or the red blood cell, then that red blood cell travels throughout the body, and wherever the oxygen is needed, whether it's in your arms, your legs, your feet, your stomach, your head, your skin, wherever it is, when it senses that oxygen is required in that part of the body when it's traveling, it just hops off and it goes to that part of the body. Okay? And then when it hops off, then whatever waste product hops on, and then it comes and it goes to the livers, the kidneys, gets filtered out, or with CO, comes back into your lungs, and the whole process takes place, and it leaves your lungs, and we breathe it out. Okay? So that's that's diffusion in the lungs. When we breathe in, we use the intercostal muscles, which are the muscles in between the ribs as part of the skeletal muscles. With that, the diaphragm goes down, creating negative pressure in the chest cavity. The intercostal muscles and the sucking pressure causes our rib cage to go up and expand. We breathe in, then we breathe out, and during that process, we have diffusion, and we have respirations taking place, and that's how we breathe. And I'm going to get to a point where you actually have two systems in your body that actually help you breathe. Actually, let's talk about that now. You have your normal breathing system, which is in your brain. And how do we know when to breathe? Does our brain tell us to breathe? Yes, it does. Is the brain on a timer and it tells us when to breathe? No. The brain has sensors throughout the body, and it reads the signals from those sensors throughout the body, and those senses or sensors measure the amount of carbon dioxide and the pH level in our blood. If the pH level changes to a point where it's not correct and there's too much CO in our blood, our brain tells our body to breathe. So our brain will tell the organ, the diaphragm, breathe. But it tells you how to breathe. It tells you to take a shallow breath, or it tells you to take a deep breath. The body needs to be in a state of what's called homeostasis. Homeostasis is when all the systems and all the organs in the human body are working together perfectly. The body's not sick, nothing's wrong with it. Everything's working smoothly. It's like a well-tuned racing engine. The engine's purring like a kitten. An engine that's working perfectly and there's no problems with it, that engine is in homeostasis. With the human body, when everything's working fine, we feel great, everything's working fine, there's no problems, we're not sick, our body is in homeostasis. There are many things that can take our body out of homeostasis. One of those things is if we have an incorrect balance of pH in the body and too much CO. So the body recognizes that by the sensors it has in the body, and the brain says, okay, let's get rid of this CO, and in doing so, we'll put the pH level back to where it needs to be. So we're going to breathe. The next two breaths are going to be really deep breaths. And in the process of breathing those two deep breaths, that's going to eliminate all that extra CO, and then the body's going to be back in homeostasis. Okay? So that's the main drive for breathing. It's controlled in the brain. Now, what happens if you have a brain injury and something injures that part of the brain, whether it's you're sick, you're ill, or whether it's from trauma, blunt force trauma or something? What happens if that part of the brain is injured and it can't tell your body when to breathe, or it's having a hard time trying to tell your body how to breathe? Well, our body has a backup system, and it's called the hypoxic drive. The hypoxic drive measures the amount of oxygen that's in our body. And if it doesn't have enough oxygen, then it tells our body to breathe. If it has too much oxygen, then it tells us to slow down, or maybe wait another second to take a breath. Or it may say, don't take such a deep breath, take a shallower breath. That's the hypoxic drive. So you got two systems to teach it. You got two systems that you can breathe with. Your main drive, that's from your brain, and it measures the CO and the pH level in your body, and that tells you when to breathe. Or if something's wrong with that system, the backup system, known as a hypoxic drive, that kicks in, and that tells us when to breathe. But that tells us when to breathe by measuring the amount of oxygen. Now, there's an illness out there that's called COPD, chronic obstructive pulmonary disease. That is one of the things we're going to talk about today. And when you're an EMT or when you're a nurse or a doctor and you have somebody with COPD and they're having a hard time breathing, you can sometimes give them some oxygen, but you have to be careful on how much oxygen you can give them, because if for some reason that person with COPD has a problem with their primary breathing, then this backup breathing system is going to kick in. That's going to measure the amount of oxygen. But if you give somebody oxygen and the hypoxic drive senses, oh, well, this person's got plenty of oxygen, you don't need to breathe that much, but this person is actually having difficulty breathing, then it's sort of like that patient is in a difficult position. They're between a rock and a hard place because they're having a hard time breathing. They need to breathe. They need more oxygen. So you're giving them oxygen, but the hypoxic drive is saying, no, don't give them too much, because now they have too much, so they don't have to breathe that much. But the patient's like, no, I need to breathe. I need more oxygen. The hypoxic drive is saying, no, you have enough. You don't need that much. So that's why, as an EMT, we're going to be with the patient for a very short amount of time, from the time we show up on scene to the time we transport the patient. Ideally, from the time that you're dispatched to the time that you're leaving the hospital after you deliver the patient and give your report, usually the amount of time is about 60 minutes. So we do have to worry about it, and we do have to keep an eye on how much oxygen we're giving a patient, but never withhold oxygen therapy for a patient who needs it. If you have a patient who needs oxygen, but they have a history of COPD, maybe start with a nasal cannula at about 2 or maybe 3 liters per minute. Every situation is different. We're going to be with the patient for a very short amount of time, so if we give them oxygen and a non-rebreather on a nasal cannula at a low liter, it's not going to do any harm to the patient. It's more when they're in the hospital, they're going to be there for a couple of days, that they're going to be on oxygen for an extended period of time, that's when nurses and doctors have to keep a really close eye on it. So those are the two drives that help us breathe. Okay. What we're going to do is, because I'm recording this on my phone, we're trying to figure out a way how to get this done, so I'm going to record it in 30-minute intervals. So we're going to have 2 30 or 35-minute intervals in this chapter. Okay, what are signs and symptoms of inadequate breathing? How do you know that a person is having a hard time breathing? Okay, so signs and symptoms. As you know, a sign is something that you see, and a symptom is something that the patient tells you. So let's discuss these. Number one, signs and symptoms of inadequate breathing. The patient reports difficulty breathing or shortness of breath. They're going to tell you, I'm having a hard time breathing. I can't catch my breath. The patient has an altered mental status associated with shallow or slow breathing. If a person is having difficulty breathing, and if it's been going on for a short or long period of time, their mental status is going to change a little bit. They're almost going to seem lethargic, like they're sort of almost out of it. And it's because they don't have that much oxygen in their system. The trick is we need to get them oxygen. We need to secure the airway, get them oxygen in the hopes that it'll help them become more alert. Another one, the adult patient appears anxious or restlessness. The pediatric patient appears sleepy or listless. When you're an adult and you're having a hard time breathing, if it's going on for a short period of time, you're going to start to panic. And you're going to start acting very anxious, very restless. Almost to the point where people are going to say, what's wrong? You're acting angry. Why can't you, just sit down and relax? You're panicking because you can't breathe. You're trying to find a way to put your body in a position where you can breathe easier. Pediatric patients, they don't move around that much. Little kids, they can't get up and walk around. So they're going to seem very sleepy. They're going to seem lethargic, listlessness. Okay. Another one, the respiratory rate is too fast or too slow. The normal respiration rate for a healthy adult is what? 12 to 20. So what happens if someone's breathing 6 times a minute? Guess what? 6 times a minute is not sufficient to sustain life. What if somebody's breathing 22 times a minute? Well, the range is 12 to 20, but if they're breathing 22, is that a big red flag to say, oh my gosh, this person needs to go to the hospital immediately or they're going to die in 30 seconds? No, it's a little high, not massively high. What if the person's breathing 30 times a minute? Well, the range is 12 to 20, so someone's breathing 30 times a minute. That probably means that they're breathing very rapidly and they're breathing very shallow, meaning that they're only filling their lungs halfway up. Well, you know what happens with that. Sometimes you're going to do that and you're going to pass out. But they're doing that because their body's trying to breathe. There's a saying that we use, under 8 or over 28, ventilate. If the patient is breathing 8 times a minute or less, or 28 times a minute or more, they're breathing too slow or they're breathing too fast. So we need to ventilate that patient. We need to grab a BVM, a bag valve mask, attach it to high flow O2. And we all know that a BVM on high flow O2, 10 to 15 liters per minute, let's say you set it at 15 liters per minute, that's high flow O2, that the oxygen saturation rate with the BVM high flow O2 is 90 to 100% oxygen. So that patient is breathing 90 to 100% oxygen. Okay? Ambient air is about, let's say 21, 22% oxygen. But when our body breathes, we only use 17, 18% of it. So let's say right now the ambient air is 21% and our body is currently using 18% of it. So we breathe in 21% oxygen, we only use 18% of it, and we exhale the difference, 18, 19, 20. So it's 3% oxygen. So we're actually exhaling 3% oxygen. Okay? Compared to if somebody's on a BVM, they're breathing 90 to 100% oxygen. So they're going to get good saturation on the hemoglobin, and their blood should be packed with oxygen, which is exactly what they need at that point in time. Another sign and symptom, the skin is cool, pale, and clammy. It's cyanotic. Cyanosis or cyanotic, same thing. Cyanosis is when you start to have purple, blue, or grayish coloring around your lips and your nose. That shows poor signs of perfusion. And perfusion is the adequate supply of oxygen and minerals to the body's organs and tissues, and then the removal of waste. So if we are breathing adequately, and we're breathing, and we've got good diffusion, good respiration is taking place, we're breathing 12 to 20 times a minute, our body's fine. If for some reason we are not getting that much oxygen into our bloodstream for whatever reason, it could be an illness, it could be build up mucus in the lungs, it could be from an injury. If we're not able to get that much oxygen into our bloodstream, then one of the first signs you're going to see is discoloration around the mouth, and that's called cyanosis. Also, your skin will become cool and clammy, sort of like you're walking out of a steam room. Your skin is very clammy, but when you walk out of a steam room, your skin's really hot. Make the skin the same condition, clammy, moist, but make it really, really cold instead of being really hot. When a person's skin is cool and clammy and pale, that also means that those are also not only signs for respiratory distress or difficulty breathing, but they're also signs of shock as well. And shock is something you guys I believe have already covered. So shock is very serious. And what are the 4 things we do for somebody who's in shock? We put them in a position of comfort. We keep them warm with the blanket. We give them high flow O2, and we give them rapid transport to the hospital to definitive care to the doctors and nurses. Okay? Another sign and symptom could be decreased or noisy breath sounds are heard on one side or both sides of the chest. If you have pneumonia, pneumonia is an illness where the lungs start to fill up from the bottom up with fluid. Could be mucus and crap and stuff like that. So if your lungs are from here to here and you're using all this space to breathe, but you've got this part down here is submerged in mucus and guck, then the only part of your lungs that are working are from here to here instead of here to here. So with less lung capacity, your respirations are going to increase, your blood pressure is going to increase, your pulse is going to increase, and you're going to start freaking out. The patient cannot speak more than a few words between breaths. So you say, you show up at the call and say, just say it's 62-year-old Mr. Johnson complaining of chest pain and difficulty breathing. I say, Mr. Johnson, how are you feeling today? I feel fine. I can't They can only say 1 or 2 words in between breaths, because the reason why their lung capacity is so greatly reduced, they can't take a deep breath. They're only taking shallow breaths, and they want to concentrate more on breathing than they are talking. So a lot of times it's very, very difficult. A lot of times they just can't breathe. They can't talk at all because they have to concentrate on breathing so much. Another one would be you observe accessory muscle use, retractions, or labored breathing. You know what it looks like when someone's having a hard time breathing, or, as I said earlier, you see the muscles up in the clavicle, they get sucked in. That's accessory muscle use. Another one would be when you listen to the lung sounds, you hear crackles, you hear gurgling. That's a lot. That means that the lungs are full of gunk and mucus, and the alveoli is not able to do that gas exchange that it's supposed to be doing. It could be the person's coughing excessively. It could be that they're coughing and they're coughing up foamy pink stuff. Okay. It could be that when they're breathing, the one side is coming up just the way it should be, but the other side is not. There could be something going on in there. Okay. There's something that's called the tripod position. The person's sitting straight up. They're sitting on the very edge of the chair with their legs spread apart and their hands like this, and they're sticking their chest out. And they're trying to make that airway as straight as possible to get as much air into the lungs as possible. Or the patient has pursed lips, which is, it's like they're blowing up a balloon because of the fact that they're having a hard time trying to push the air out. They can bring it in, but they're having a hard time getting the air out of their body. Or their nasals are flaring, and their nose gets really, really wide when they want to take a breath in, then they breathe out. Breathe in, breathe out. The body's trying to make all the openings of the human body to the airway maximize their size in order to maximize the amount of air that's coming in. So that's table 15.2, and that's on page 588. Make you guys take a look at it. Now, there's very respiratory conditions that can be taking place in the human body. Okay? Let's see. Let's talk about, there's asthma, there's anaphylaxis, there's bronchitis, there's CHF, the common cold, there's croup, epiglottitis, and emphysema, along with many other ones. So we already talked about the hypoxic drive. Let's see. Okay, so let's talk about, let me see here. What are we doing here? Okay, cool. So, there are certain things, what's going on in the world right now? Okay, we got the COVID-19, and they're talking about people wearing masks. There's a lot of different masks that you might see people wearing out in the field. The most common one that you see is a general mask that does an okay job keeping certain, large particulates out of our airway. It's a mask you see where they put over, they wrap it around their ears, and they open it. It's folded and looks like an accordion, and they pull it out like this, and it covers their nose and their mouth. It looks like a small piece of cloth that they open up and they cover it. Okay, that's a generic. In the old days, they used to call those surgical masks. Okay, allows you to breathe very, very easily. It lets a lot of things in. Doesn't do that good of a job, but it does an okay job. And that's the most common one that you're going to see out there that people are wearing. That's what average Joe Schmo is wearing. It's a square. It's like a rectangle, and they can open it up a little bit. There's another one that's called the N95 respirator. It is very, very good. This is more of the round one you see people wear, usually first responders, doctors, and nurses. The N95 is very, very good. It keeps a lot of the smaller particles that you can't see. It stops them. It does a better job filtering those particulates out of the air. So those microscopic particulates that we can't see, the old surgical mask, those will let them in and out. Really doesn't do that much, but the N95 does a great job. The particulate you're breathing in, and it gets caught in this mask, and it stays right there. You don't breathe it in. Those are really, really good, and those are the most common ones you're going to see doctors and nurses wearing right now when we have a big enough supply. So Some of the diagnoses that people can have with breathing difficulty, one is called croup, and croup is caused by an inflammation and swelling of the pharynx, larynx, and trachea. Okay, with that, basically the upper airway, it gets inflamed, it gets infected, it gets inflamed, and by inflaming that, the diameter of the airway, which is normally, I just over exaggerate, is this big. Okay, so let's say that area becomes infected, it starts to swell. Well, when it swells, what happens? It gets smaller, and it gets smaller, and it gets smaller. It gets so small to the point where you have a really hard time breathing. Now, with croup, there's something that's called stridor. Stridor is a seal bark cough, which signals a narrowing of the air passage of the trachea. And what that basically is that when the person coughs, they're going to sound like a seal. And a seal goes, ooh, ooh, ooh. But when somebody coughs, they're going to go, ooh, ooh. And that's what it sounds like. So let me see here. Okay, I've got 4 minutes left within the first 30 minutes. Another one is called epiglottitis. Now, basically what that is this epiglottitis is a life-threatening inflammatory disease of the epiglottis, which is a small flap of tissue at the back of the throat that protects the larynx and trachea during swallowing. So you have the larynx and you have your trachea. Okay, you've got two tubes. One's in the front, one's in the back. Just go like this. Okay, one's in the front, one's in the back. So you have this little leaf-like structure, two tubes that are right next to each other, and this leaf structure that goes back and forth, and it protects it. So when you're drinking a glass of milk, you want that to go into your stomach, not to your airway. So what it does is that little epiglottis, that little leaf-like structure, it says, whoa, here comes some liquid, milk, water, soda, whatever it is, beer, whatever. It flaps over and it protects your airway, allowing the liquid to go straight down into your stomach. Same thing when you're eating food. When you're eating, your brain says, whoa, here comes, hey, epiglottis, here comes some food. So it covers your airway and lets the food go down to your stomach. But when you're breathing through your mouth or through your nose, and you're not eating or swallowing, because you can't do both at the same time, and when you do, liquid or food particles go down to your lungs, and that's what causes you to cough. When you're breathing, that little leaf structure covers the stomach, and it opens up the airway, and it lets air go in and out of your lungs. When that leaf-like structure becomes infected, it becomes swollen. And when it becomes swollen, it has a hard time. It's not as fast covering whichever tube it needs to cover. So in that case, you might swallow some water into your lungs, and you're going to cough it up. It's very dangerous for very, very young kids because of the fact that when it does close the airway, when you're swallowing, it can't close that well. Allowing food or liquids to get into your lungs. So it's not as effective. So they would give that person high-dose antibiotics. Okay, that does it for the first 30 minutes of the class. I will be back with remaining other 30 minutes.